Good morning. My topic is Phakic IOL for the beginners. I don't have any financial interest on the topic or the products which I mentioned here. So the goal of any phakic IOL surgery or any refractive surgery is to provide emmetropia without possible change of diffraction in the long follow-up. We have various surgical procedures that are available today, but all have their own merits and limitations. If you see LASIK in high emmetropia, there can be residual errors or there can be loss of best corrected visual acuity. The patients can have poor mesopic vision or poor quality of vision. Whereas in case of phakic IOLs, they have a lot of advantages. It gives excellent refractive accuracy with the preservation of corneal sphericity. We are not going to touch the cornea, so we are maintaining the corneal sphericity and preservation of accommodation. And the healing is highly predictable. And phakic IOLs, the other advantages are like it's reversible and you can adjust. You can just, if there is an axis change, you can just go ahead and rotate the lens and correct the refractive error. And there is rapid recovery, visual recovery and stable postoperative refraction. So these are some of the indications, common indications: high myopia, high hyperopia, or high myopic astigmatism, and even stable keratoconus or treated keratoconus with good best corrected visual acuity. If the patient has 6/6 with the glass correction, these are the right candidates for phakic IOL implantation. And mild to moderate myopia also with limited corneal thickness or corneal weakness. These are the cases wherein we can try phakic lenses. So these are some of the phakic lenses that are available in the market today. I'm not going into the details of these lenses. Better understanding of these lenses is extremely important for with the proper orientation, the lens orientation within the eye. The surgeon should know the position of the lens, and this can result in optimal outcome. If you look at the IPCL, there are two holes in the optic. These two holes should face superior. If we are dealing with the right eye, then these two holes should be towards your left hand side, and if you are dealing with the left eye, these two holes should be towards your right hand side. And in case of ICL from Star Surgicals, and there are two implantation holes, that is like in the leading right and trailing left. So this should always be followed. The leading right should have the hole and the trailing left should have the hole for proper orientation of the lens within the eye. And phakic IOL candidates require a comprehensive workup to rule out any potential anatomic or physiological problems. So these are some of the basic investigations which we need to do: visual acuity, best corrected acuity, refraction, slit lamp examination, IOP measurement, and fundus examination. ACD and white to white measurement is extremely important, and keratometry, specular microscopy, and topography. These are some of the basic investigations. And we need internal antechamber depth, that is for customization of these phakic lenses. And if the ACD is taken from a scan which measure external antechamber depth, we have to deduct the pachymetry from the whole value. And some equipments like pentacam, it gives internal antechamber depth. So it should be more than 2.8 millimeters. And horizontal white to white measurement from mid limbus to mid limbus is extremely important. So the measurements of white to white distance using a caliper has been proven to be a simple but a reliable method. And we should make sure that the caliper is well calibrated and you pre-treat the eye with the anesthetic drops. proper calculation and sizing is very important because sizing will determine the fit and overall success of these phakic lenses. Selecting an appropriate lens size is based on the measurement of patient's white to white distance, which is just an indirect measurement of sulcus to sulcus. There are various instruments that are available for white to white measurement. And the preferred one is actually, with the experience we have done quite a good number of phakic IOLs. With our experience, I could say that the digital caliper is the best way to measure white to white measurement. It can be cross-checked with the topolizer or pentacam values. And precise definitions for insufficient vault and excessive vault have, however, remained elusive because only a percentage of eyes with vault beyond any predefined range experiences vault-related adverse events. So if you see here, there's a very low vault in both the cases, but in this particular case, the crystalline lens is very clear, but in this case, it's already started developing anterior subcapsular opacification. And many authors have reported a range of values for the limits of safe vault based on the likelihood that cataract or pupillary block may occur beyond that range. And there are various studies. So many of these authors have suggested from 150 microns to 1000 microns is the acceptable limit, but we suggest 250 microns to 750 microns is the ideal vault that should be aimed for. And phakic IOL replacement. So this particular study, which was published in JCRS 2015, actually they suggested if the vault is less than 100 microns or greater than 1000 microns, the phakic IOL has to be replaced. And if the lens comes direct contact with the crystalline lens, if there is a shallow AC with the closure of angle in any quadrant, or if the vault is greater than 1000 microns with mid-dilated pupil, and if the patient is symptomatic, having a constant glare. So these are the conditions wherein we have to replace the posterior chamber phakic implant. So there was a meta-analysis which was published in Clinical Ophthalmology, which was published by Doe Press, wherein they have studied 1400 eyes and reported only 4 eyes with anterior subcapsular opacifications, and out of which only 1 patient required surgery. So it is just 0.1% of the entire series. So that is a very small percentage. The chances of anterior subcapsular opacification, if all the rules are followed, is very less. And there are a few more studies which also have shown that there can be anterior subcapsular opacification, but the significant anterior subcapsular opacification which requires surgical management is minimal. This is some of the cases showing anterior subcapsular opacification. This is our own case where the patient had developed anterior subcapsular opacification and needed surgical treatment. Not able to. Yeah. So it's very easy actually. You can make a same incision. The incision size should be the same as your phaco incision. 2.4 millimeters is sufficient to remove these lenses. It's highly flexible lenses, and most often these anterior subcapsular opacifications are in young patients. Most of them don't have nuclear sclerosis. It's very easy to aspirate these cataractous lenses and replace it with the posterior chamber intraocular lens. This is another case which is showing a very high vault. The vault here is around 1110, And these are the cases which can lead to symptoms and can have secondary angle closure. And you can see the angles here, so very narrow angles, and this particular patient needs replacement. Another 30 seconds.
Can take another 2-3 minutes.
Okay, okay. So, needs a replacement. If you yeah. So it's just you have to flip it into the anterior chamber. It's a highly flexible lens. It's not like your intraocular lens wherein you have to cut the lens. Here you can just flip it into the anterior chamber, and with the help of holding forceps, you just pull it through the same incision. It comes out easily without distorting the incision, and then you replace it with the new lens. You need not enlarge the lens, enlarge the incision. And a few case examples. This particular case, the patient has a high myopic astigmatism and it's anisometropia. In the right eye is amblyopic with a very high spherical power, and left eye has 10 diopters of myopic astigmatism, and the right eye 618 is the best corrected visual acuity, left eye is 66. And the anterior chamber depth is sufficient, 2.98 millimeters. The other eye 2.9 millimeters. And this is the toric ICL implantation, toric sheet. And post-operatively, the patient has improved to 612 parts in the right eye and 6.5 in the left eye. So there is actually half a line improvement in the right eye and 1 line improvement in the left eye. Similarly, this particular case is a post-C3R patient who has undergone C3R 5 years back, and he has a residual astigmatism of 3 diopters and a spherical power of 3.75 diopters, but improving to 6/6. So the cone here is almost central. It's not a highly decentered cone, but the visual acuity is improving to 6/6. This has to be understood. Any keratoconus patients, if the visual acuity is good with the glasses, these are the candidates which can be implanted with phakic IOLs. And the post-operatively, the patient is doing well, 6/6 plano. Another third case has got a mixed astigmatism, and the visual acuity is improving to 618 parts, and we suggested Intax plus CXL for this particular patient. You can see a highly decentered cone here, and we have to recenter the cone by doing Intax with the CXL, and post-operatively after Intax plus CXL, the visual acuity has improved to 6/9 because of the recentration of the cone. This is the centered cone now, and the visual acuity has improved to 6/9, and for the residual error we implanted phakic lens. And post-operatively, the patient is doing well. The uncorrected visual acuity has improved from 5/60 to 6/9, and post-operatively, with the best corrected visual acuity, it is 6/9. And the loading of these lenses is extremely important. Is extremely important, and if these company people will come and demonstrate how to load these lenses, because the proper orientation of these lenses in the anterior chamber is extremely important. To conclude, acute preoperative measurements can give rise to perfect vision after phakic IOLs, and there has been improvements in best corrected visual acuity up to 1 to 2 lines. And the quality of vision can be great by preserving accommodation and maintaining a corneal sphericity. Thank you very much.
Thank you, Dr. SHREESHA Kumar. Since Dr. Mohan Rajan has not turned up, we wind up this session. Before that, any questions to Dr. SHREESHA Kumar?